Thank you very much. I'm Péter Elek, and I'm rather a health economist, but thank you for having the opportunity to present here our research. So it's about geographic and socioeconomic variation in healthcare, evidence, and we give evidence based on migration, so based on within-country migration. So the motivation is that we know all well that there are large socioeconomic differences in health and healthcare use, even in developed countries. Low-income groups have worse health on average, and effective access to healthcare may differ across groups. We know it quite well. But we know also that even across all types of healthcare systems, from the United States through Germany, Austria, and also in Hungary, which I focus on, there is large geographic variation in healthcare use. For instance, in Hungary, there are maybe 1.5 difference between the highest and lowest spending areas in healthcare use. And we want to understand what are the drivers of these differences. So if we look at this, so this is Hungary I'm talking about, and this is just a map of Hungary, and the geographic units are districts, which are approximately 200 districts of Hungary. So each district contains approximately 50,000 population, and we see that there are large discrepancies in outpatient spending, inpatient spending, and drug spending. But the patterns are quite different, so we may think about what drives these geographic differences in various types of healthcare use. So if we think about the drivers, we may think that there are two types of differences. One is what comes from that there is a different composition of patients in different districts, so health status or preferences of patients can be different in different regions. And of course, there is the place effects as well, which means that there are different supply of healthcare in different regions, maybe measured by capacities, available number of physicians, equipments, the physicians' beliefs, and maybe there are some other differences, for instance, local climate conditions. It doesn't apply in Hungary, or local economic conditions may play a role. So we want to decompose the variation in district-level differences in healthcare use into these two types of variation. So one, we can say that one is from the demand side. This is about the patients, and the other is the supply side. This is about the characteristics of the place itself. If we don't have movers, then we may use statistical techniques and control for observables and so on, but we want to exploit the movers between districts to disentangle these two types of effects. Meaning that if someone moves not of health reasons from one region to another region, then the patient characteristics will not change largely, but the place characteristics will change. Okay, so that is the basic idea of disentangling these two types of things based on the movers. And if there is high place share, that means that there may be some inefficiencies in the supply of healthcare. And if there is heterogeneity in these place shares, then understanding the sources of these heterogeneities can help to target healthcare policies to decrease these differences. There is a large related health economics literature which uses movers to identify the sources of regional variation in healthcare. This comes in the last maybe 10 years, and it decomposes and finds that in some countries this share is quite low. For instance, in Germany, at least in ambulatory care, the place shares in differences is quite low. But for instance, in the United States, it's quite large. We want to see what's happening in Hungary. And the second step we want to measure heterogeneity of these place shares, these place components across socioeconomic groups, that for instance by income and so on. Okay, so that is what we want to do. Maybe I would like to talk a few words about the public healthcare system in Hungary. It's quite simple, actually, because it's a single payer system with a universal coverage, which is actually free at the point of use, apart from pharmaceuticals, so there are no differences in prices paid by the people. And of course, the financing part is different, and actually there are 3 or 4 levels of this healthcare: primary care, specialist outpatient care, which comes after the primary care, and it's available in almost all district centers, and inpatient care hospitals, which are available in half of the district centers. But of course, there are different levels of hospitals and different levels of care provided by hospitals. So these are the 3 types of care, and of course there is the care for pharmaceuticals. We use a quite large and detailed data set, which is an administrative individual level panel data set of Hungarian population, half of the Hungarian population, stemming for almost 10 years, and it matches healthcare and labor market variables as well. On the individual level, we have demographic information, of course, especially the districts. So we have district level information where they are located, healthcare information by specialties, by ATC categories in pharmaceuticals, and so on. And most importantly, we have labor market characteristics, so we can see the earnings, pensions, and labor market status of the people. Okay, so this is the data set, and we exploit the movers. Okay, so we exploit that if someone moves from one district to another out of this 200 districts, and examine what happens with their healthcare utilization. Basically, this is what we do. We make some restrictions on movers, but I think this is quite technical. And the model is really a two-way fixed effects model. So we have individual fixed effects, which is about the unobserved and time invariant characteristics of the patients, and we have the district effects, which are what is the place characteristics, and based on movers, we can disentangle these two things. Without movers, we couldn't do it just by controlling for observables and so on. And so that is our main specification. And if we make it into a difference in differences specification, actually this can be translated into a very simple thing, meaning that if a person moves from district A to district B, what happens with his or her utilization compared to delta I? Delta I means the difference in utilization, average difference in utilization between the destination and the origin district. And the share shows what is the place share, what is the share of the variation to place, and all the others will be share attributed to the patients. Okay, so theta is the parameter which we are most interested in. And this can be done in an event study framework where we don't only observe the whether before or after things, but what happens, for instance, 2 years after the move, 2 years before the move, and so on. Okay, so that is the two types of specification which we use. But I think these are the basic event study graphs, which means that, for instance, if 0 is the year of move, and before the move they are roughly 0, there is some small trend, but after the move these shares go up to 0.6, meaning actually that if someone moves for a higher or for a lower utilization district, then the average difference between the two districts will be translated 0.6 times into his or her individual utilization in outpatient care. This is quite large compared to the international literature. Even in the United States, it's around 0.5. But if we look at other types of care, then we can see that, yes, outpatient care has the highest share, almost 2/3. Inpatient care doesn't have. So actually, inpatient spending is not really affected by where the resident resides. But drug spending also has some share. If we decompose it to different categories, then antibiotics is the most affected. Other types of pharmaceuticals, for instance, antihypertensive drugs, antidiabetics, do not seem to be much affected. What we have in by heterogeneity of the place shares by income groups, for instance. So here, from the administrative data set, we know what is the income and the labor market status 2 years before the move of the people. And we can see very, very high heterogeneities. So for instance, among the non-working, working age population, or income level, which is in the lower quartile. So for instance, Q1 is the income level of the lower quartile, end of the distribution. The place shares are quite high, and if we are in the higher income levels, in higher socioeconomic status, then the place share is much lower. This is the same for pensioners as well. So actually we can see that place share is higher among low socioeconomic status people. Actually, this is not driven by differences in health. It can be checked. So the question is, what constrains their utilization by place effects? Okay, so that is the second question. So what kind of supply side constraints are there, which disproportionately affect the low income people? And what can be done? We can have the same types of estimations, but we examine what drives the healthcare utilization of movers, provided that we can measure a lot of things. For instance, we can measure outpatient capacities in different districts, socioeconomic factor of different districts, and so on. So we make the movers as well, but here on the right-hand side, we measure outpatient capacities and other type of hospital beds, geographic location, distance from the county seat, and the socioeconomic conditions of the district. Okay, and check what determines the healthcare utilization of movers out of these variables. I think it's a basic question in health economics, because we know, for instance, that higher outpatient capacities are coming with higher use of outpatient care, but whether this is because of demand side or this is because of supply side, we don't know, but based on movers, we can look at it. And if we look at these, we see that, yes, there is a large effects of outpatient capacities on the healthcare utilization of movers, and there seems to be some substitution between outpatient and inpatient care, so where there are more hospital beds, then there is a smaller outpatient utilization of movers, and vice versa. So there is a substitution between the levels of care, and I don't show here, but we see even stronger effects for women and low socioeconomic status patients if we have the same regression of healthcare utilization on outpatient capacities based on the movers. So these two things connect our two findings. First, the larger constraint of place for low socioeconomic status people, and second, that the capacities indeed influence more the healthcare utilization of low socioeconomic status patients after moving. So actually, we did much more than that, but I think that based on this 10 or 12 minutes, I think this was what I could say. So to conclude, place effects account for a large part of the variation in outpatient spending, smaller for drug spending, and essentially zero for inpatient spending. There is substantial heterogeneity in outpatient place shares, and there seems to be a positive association between district-level outpatient spending and capacities, and both are quite larger for females and low-income groups. So which means that even in a healthcare system which is universal, at least in principle, there are inefficiencies in the supply side, and this mover-based identification may be a good chance to examine these heterogeneities as well. Thanks very much for the presentation.